Hi, my name is TJ Strong, and I am a student pharmacist at DUVL School of Pharmacy, and the title of my journal club is Safety and Efficacy of Linagliptin as Add-on Therapy to Metformin in Patients with Type 2 Diabetes. And I picked this article because linagliptin is a newly approved anti-diabetic drug, and I wanted to see how efficacious it is in lowering A1C and glucose levels. The authors are Taskinen et al. I received this journal from Diabetes, Obesity, and Metabolism 2011. The primary objective is to evaluate the efficacy and safety of linagliptin 5 mg versus placebo as add-on therapy to metformin in patients with uncontrolled diabetes. The primary efficacy measure is a change from baseline in hemoglobin A1C after 24 weeks of treatment. The study design is a prospective, randomized, double-blinded, placebo-controlled parallel group study. The subjects were male and female patients aged 18 to 80 years, previously diagnosed with type 2 diabetes. Inclusion criteria, a couple of them include patients 18 to 80 years of age, previously diagnosed with type 2 diabetes, BMI less than or equal to 40. Subjects need to be receiving metformin at a dose greater than 1500 milligrams per day and not more than one other anti-diabetic medication. A couple exclusion criteria include treated with rosiglitazone, pioglitazone, a GLP-1 analog, insulin or anti-obesity drug within 3 months, or had changed their dosage of thyroid hormone treatment within 6 weeks, or were being treated with systemic steroids at the date of informed consent. Also, impaired hepatic function, renal failure or impairment, past MI, stroke, or TIA within 6 months of giving informed consent, history of acute or chronic metabolic acidosis, unstable or acute congestive heart failure. The study period, the linagliptin and placebo treatment lasted 24 weeks, along with a 1-week follow-up. Monitoring. Patients' hemoglobin A1C were monitored at weeks 0, 6, 12, 18, and 24, and at the week 25 follow-up, and were educated on the correct use of home glucose monitoring and received dietary counseling. The data analysis. The primary analysis of primary outcome measure was done on an intent-to-treat population with alpha set at 0.05. Power was calculated for the primary outcome measure of change from baseline in hemoglobin A1C after 24 weeks of treatment. A sample size of 600 patients, 450 patients of the linagliptin group and 150 in the placebo group, would provide a power of 95%. Table 1 describes a statistical analysis of the data. The ANCOVA and logistic regression tests were used to analyze the change from baseline in hemoglobin A1C after 24 weeks of treatment and were appropriate. For the results section, Table 2 depicts glycemic efficacy between the linagliptin and placebo treatment groups. As you can see, linagliptin decreased the subject's A1C by an average of 0.49, whereas a placebo increased the A1C by an average of 0.15, leading to an adjusted mean treatment effect of negative 0.64, which is significant with a p-value of less than 0.0001. The adjusted mean treatment effect of fasting blood glucose for linagliptin was negative 21.6 milligrams per deciliter, with a p-value of less than 0.0001. Of 2-hour postprandial glucose was negative 66.6 milligrams per deciliter, with a p-value of less than 0.0001. Therefore, this further supports the addition of linagliptin to metformin in type 2 diabetics. For the subjects in the study, 2 oral anti-diabetic medications are not sufficient enough to lower the glucose levels within the target range of less than 100 milligrams per deciliter. For fasting blood glucose, less than 180 milligrams per deciliter for 2-hour postprandial glucose, and less than 7% for hemoglobin A1C. These subjects will most likely be on additional oral medications if not started on insulin. For tolerability, Table 3 illustrates the summary of adverse effects. As you can see, the placebo group had a higher incidence of hypoglycemia, 2.8% compared to 0.6%. Hyperglycemia, 14.7% compared to 5.2%. Urinary tract infections, 4% compared to 3.1%. And headaches, 4% compared to 2.9%. Whereas the linagliptin group had a higher incidence of influenza, 13.4% compared to 2.8%. Therefore, we can conclude that an adverse effect of influenza might deter patients from remaining adherent to this medication. For the author's conclusion, patients who are inadequately controlled on metformin monotherapy, the addition of linagliptin 5 mg over 5 mg once daily over 24 weeks provides excellent glycemic improvement and control. Linagliptin provides good coverage for pre- and postprandial as well as hemoglobin A1C. There was a low incidence of hypoglycemia and weight gain when compared to the placebo, making it well tolerable. The strengths of my article. Power was set and met. Biostatistical test was appropriate for the data type. Outcome measure was valid. Inclusion-exclusion criteria were adequate. Randomization resulted in similar groups. Length of the study was appropriate to show effect. Treatment regimen was appropriate. Blinding was sufficient to mask the data. And the author's conclusions were supported by the results. Limitations. The authors did not discuss any limitations of their study, but I did find out that the study was author bias. A couple of the authors were employed at Boehringer Ingelheim, the company that trademarked Tradjenta. The level of evidence was 1 with minor limitations. Therefore, I strongly recommend the addition of linagliptin to metformin for type 2 diabetics over the age of 18 years of age with poorly controlled diabetes. For efficacy, this level 1 trial demonstrated statistically significant results for the change from baseline in hemoglobin A1C after 24 weeks of treatment of linagliptin versus placebo, with a p-value less than 0.0001. For safety, the safety profile of the linagliptin group compared to the placebo group was quite different. The placebo group had a higher percentage of patients experiencing hypo and hyperglycemia, urinary tract infections, as well as headaches, whereas the linagliptin group had a higher incidence of influenza. Overall, there were no serious adverse effects reported for the patients taking linagliptin for 24 weeks. Cost. Linagliptin is not available generically. Tradjenta is the brand name, and a 30-count bottle of the 5 mg strength is roughly $270. Since Tradjenta is a newly formulated anti-diabetic medication, the drug might have unknown long-term adverse effects. This could be a potential indirect cost of taking this medication for a prolonged period of time. For special considerations, it is unknown whether linagliptin is excreted in the breast milk. Therefore, caution should be used if administered to breastfeeding women. And also, linagliptin is a substrate for CYP3A4. Therefore, inducers, for example herbs, and inhibitors, for example antifungals, of this enzyme should be screened prior to initiation. Thank you for your time. If there are any questions, feel free to email me. Thank you.